Okay, let's unpack this. We are diving deep today, really deep, into a critical topic, pulling from a set of revision notes you've shared with us.
Yes, good notes too. Very concise.
Exactly. And our mission, simple, extract the absolute highest yield need-to-know info on placental abruption.
Right.
Think of this as your shortcut, to getting up to speed on a really serious condition quickly, effectively, especially if you're prepping for exams or just need that sharp clinical edge.
And it is serious. Placental abruption, or abruptio placentae as it's formally known,
Right.
it's definitely a major obstetric complication.
So what is it at its heart?
Basically, it's when the placenta peels away, detaches, from the wall of the uterus before the baby is born. Understanding that and what follows is just crucial in obstetrics.
Absolutely vital. And we're going to use these notes like a map, right, to navigate from the definition, how you spot it, what you do.
All the essentials.
And this deep dive, it's really tailored for you, the listener, who needs to get the core facts locked in fast.
Okay, so let's start right there with that core definition from the notes. Placental abruption. Premature separation of the placenta from the uterine lining. Simple as that, fundamentally.
Okay, but when that simple separation happens, what are the immediate sort of knock-on effects, the consequences these notes point out?
Well, the big immediate issue is the disruption to that critical blood supply line between mother and baby.
The lifeline, really.
Exactly. The notes highlight it leads straight to maternal hemorrhage bleeding, sometimes massive bleeding into that space, opening up between the placenta and the uterus wall.
And that causes two big problems.
Two huge problems. One, it compromises the oxygen supply to the fetus because that whole exchange system is interrupted. Two, it can cause really significant, potentially life-threatening blood loss for the mother. It's a major cause of, bad outcomes, morbidity, and mortality for both.
Okay, wow. So yeah, definitely not just a minor bleed. We're talking cutting off the baby's oxygen and potentially severe hemorrhage for the mom. That really hits home how serious this is from the get-go.
Precisely. And the notes, they also break down how this can present slightly differently. The types of abruption.
Yes, concealed versus revealed. What's the difference there clinically, and why does that distinction matter?
So the notes mention two main types. Concealed abruption, that's less common, maybe 20% of cases.
Okay.
And here, the blood actually stays trapped. It's stuck inside the uterus, between the placenta and the wall. This is often the more dangerous type.
Why is that? Because you can't see it.
Exactly, because you don't see the obvious external bleeding. The severity of the hemorrhage can be really underestimated, at least initially.
Right.
Then you have revealed abruption, more common, maybe 80%. Here, the blood finds a way out. It drains through the cervix.
Yeah.
And the detachment itself is usually incomplete in these cases.
Okay, that makes sense. Concealed is like that dangerous leak behind the wall. You don't see it, but major damage is happening.
Yeah.
Revealed is the leak you can see, which, while still very serious, gives you a more immediate visual clue.
A clearer warning sign, yeah. Though still an emergency.
Definitely. The notes also mention marginal hemorrhage separately, don't they?
Yes, they do. That's described a bit differently. It's usually a painless bleed, often from a small vein rupture right at the edge, the margin of the placenta, a marginal sinus rupture. You get a clot forming right there at the edge.
And management?
Observation, fetal monitoring. It's generally less severe than a full-blown abruption, but obviously still needs careful watching.
Got it. So a distinct thing, maybe less dramatic, but still needs attention. Okay, let's talk numbers. How common is this actually, and what do the stats say about how serious it is when it does happen?
Well, looking at the epidemiology here, it affects somewhere between 0.3% and 1% of pregnancies.
Okay, so not super rare, but not every day either.
Right. The UK estimate given is around 0.5 to 1%. That translates to roughly 1 in 200 pregnancies.
Yeah.
Maybe 6.5 pregnancies per 1,000 births, something like that.
So yeah, frequent enough that anyone in obstetrics or emergency medicine needs to be really sharp on recognizing it.
Absolutely. And here's the statistic that really underscores why it's so critical. The perinatal mortality rate. That's the risk of the baby dying around the time of birth.
What's the difference?
It's stark. The notes cite 11.9% mortality with abruption, compared to just 0.8% in pregnancies without it.
Wow. Just let that sink in for a moment if you're listening. That's a huge leap in risk, over 10 times higher.
It is a massive difference.
It tells you immediately, doesn't it, that when this happens, the danger to the baby is incredibly high. It really highlights the urgency we need to talk about in management.
That mortality figure is definitely a key takeaway, a sobering one.
So let's switch gears to the big question. Why? Why does this happen? What causes it? What are the risk factors?
Well, this is one of the frustrating parts. The notes are quite clear.
Mm-hmm.
The specific cause is often unknown. We can't always pin it down.
Hmm. That's tough for prevention then.
It is. But what we do have is a pretty solid list of risk factors, things that definitely increase the chances of it happening.
Okay, lay those out for us. What are the key ones, especially the biggest risk?
The single biggest risk factor, the one that stands out in the notes, is having had a previous abruption.
Ah, okay. History matters hugely here.
Massively. If it's happened before, the risk in a subsequent pregnancy jumps significantly. Then you've got maternal hypertension, high blood pressure, and pre-eclampsia. Those are major players.
Okay. Conditions affecting blood vessels.
Exactly. And trauma is another big one. Abdominal trauma, from car accidents, falls, domestic violence, unfortunately, or even certain medical procedures like amniocentesis sometimes.
Right, direct physical impact.
Yep. Then lifestyle factors. Smoking, definitely.
Yeah.
Drug use, particularly cocaine or amphetamines, is strongly linked.
Okay, that list already gives some different angles. Trauma seems direct, but hypertension, drug use, that maybe points to underlying vascular problems. Issues with the blood vessels supplying the placenta.
That's often the thinking, yes. It fits with the idea of disrupting that blood flow. The list goes on, though. Things like advanced maternal age, carrying more than one baby. It's about twice as common with twins, the notes say.
Twice as common, wow.
Yeah. Also, having had a previous C-section, the baby being in a non-vertex position, so not head down. Certain medical conditions like thrombophilia, which affects blood clotting, or intrauterine infections.
Okay.
And finally, things like polyhydramnios, that's too much amniotic fluid, and some structural uterine abnormalities are also mentioned.
So it's a real mix. Medical conditions, past history, lifestyle, pregnancy specifics. Even if we don't know the exact trigger in every case, knowing this list is crucial for you listening. It helps flag pregnancies that might need closer watching or a higher index of suspicion if symptoms pop up.
Absolutely. It's about being aware of the heightened risk. Now, moving from the why to the what's actually happening inside, the pathophysiology. The notes describe the basic mechanism pretty simply. The placenta separates from the uterine wall.
Okay, let's unpack that. It sounds straightforward, but the biological impact is huge, right? How does that physical separation cause the problems we talked about earlier?
Well, that separation directly messes up the whole maternal-fetal interface. That incredibly complex connection where oxygen, nutrients, waste products, everything gets exchanged.
The critical bridge.
Precisely. And separating it immediately impairs or even cuts off the fetal blood supply. That leads very quickly to fetal hypoxia, lack of oxygen, which we then see as fetal distress on monitoring. So while the mechanism is separation, the underlying processes often involve problems with the blood vessels, inflammation, right at that crucial connection point.
It's just such a stark reminder that the placenta isn't just there. It's this active, vital lifeline, and tearing it away is a true emergency for the baby's oxygen.
It really is. Now, critically, when someone pregnant presents with vaginal bleeding, especially later in pregnancy, abruption isn't the only possibility. And this is where thinking about the differential diagnosis is so important.
Why is getting that distinction right so vital so quickly?
Because the management plan can be completely different depending on the cause. Getting it wrong, mistaking abruption for something else, or vice versa, well, the consequences could be disastrous.
So what are the main things you need to rule out, according to these notes?
The notes list the key differentials for significant bleeding in later pregnancy. Number 1 is placenta previa. That's where the placenta is positioned low down, covering the cervix.
Okay.
And the other major one is uterine rupture, an actual tear in the wall of the uterus itself. Very serious, too.
Right. So you've got to figure out fast. Is the bleeding from a low placenta previa, a torn uterus rupture, or a detaching placenta abruption? Because what you do next totally depends on that.
Exactly. Spot on. Which leads us perfectly into the signs and symptoms. What do you actually see? What does the patient feel? This is the clinical presentation, the features from the notes that should make you think, could this be abruption?
Okay, this feels like super high-yield stuff, especially if you're the first person seeing the patient. What are the common signs listed?
The common things are vaginal bleeding, but importantly, this can range hugely from just a bit to torrential. Uterine tenderness or actual pain. Back pain is common too. Abdominal pain, maybe contractions, and signs of fetal distress, like the baby not moving as much. And of course, in severe cases, the mother showing signs of shock.
Okay. Are there any really characteristic features, things that particularly point towards abruption, maybe even slightly counterintuitive signs?
Yes. The notes highlight some really key clinical features. One is shock that seems way worse than the amount of blood you can actually see coming out.
Ah, that mismatch again.
That's a massive clue, especially hinting at that concealed type where the blood's pooling inside. Constant pain is also really typical. It's often described as different from labor pains, which come and go. This is more relentless.
Right.
And then the abdominal exam finding. The uterus feels tender and very tense or firm. The notes use the classic description, a woody feel.
That woody feel, that's such a specific, memorable description. What does that physical tenseness actually mean is happening inside?
That rigid, board-like feeling. It strongly suggests the uterus is full of blood from the hemorrhage. It's distended and contracting down hard on that trapped blood. It's a very strong indicator of a significant, often concealed, abruption.
Okay, what else?
Other features noted. The gabies position, the lie, and presentation might actually be normal, unlike in some other complications. But the fetal heart rate, that could be absent altogether or show clear signs of distress. And coagulation problems, issues with blood clotting are common and kind of expected more severe cases because the body uses up all its clotting factors trying to stop the internal bleeding.
And cautions mentioned.
Yeah, the notes remind you to be cautious, be vigilant for associated things like pre-eclampsia, which is also a risk factor itself, DIC, that's disseminated intravascular coagulation, a really dangerous widespread clotting and bleeding state, and anuria, lack of urine output, which can signal severe shock or kidney damage.
Okay, so if you put those pieces together, constant pain, maybe back pain, a tender, hard, woody uterus on exam, potentially signs of shock that don't quite match any visible bleeding, and worrying signs from the baby on the monitor. That combination should be a massive red flag screaming, think abruption.
Absolutely. Recognizing that specific pattern is the crucial first step towards taking rapid action.
Which brings us neatly to investigations. If you suspect it based on these clinical signs, how do you confirm it? Is there a definitive test?
And this is probably one of the most important points from these notes, especially for exams, but also for real-world practice. You need to burn this in. Placental abruption is primarily a clinical diagnosis.
Primarily clinical, meaning?
Meaning there isn't one single blood test or scan that's highly sensitive or reliable enough to definitively say, yes, it's abruption, or no, it isn't, every single time.
So you don't wait around for the perfect scan result before acting?
Absolutely not. You can't afford to. The clinical picture, what you see, what you feel, the patient's story, that is paramount. The clinical exam finding that tense, tender, woody uterus, that strongly suggests a significant abruption is happening right now.
What about ultrasound then? Does it have a role?
It does, but with limitations. The notes say ultrasound is not always reliable for actually seeing the blood clot, the retroplacental hematoma. Sometimes it can look quite similar to the placenta itself, or it might be missed. However, and this is important, if an ultrasound does show features suggestive of abruption, then the likelihood of it actually being present is very high.
Okay, so it's useful if it's positive, but a negative or normal scan doesn't rule abruption out if the clinical signs are there.
Precisely. You trust your clinical findings first. A cardiotachograph, the CTG, monitoring the baby's heart rate, that's vital. It can show signs of fetal hypoxia, lack of oxygen through abnormal heart rate patterns. That strongly supports the diagnosis if the other signs fit.
And labs, blood tests.
Labs are important, yes, but more for assessing the severity and looking for complications, rather than for the initial diagnosis itself. Things like a low platelet count, or checking coagulation function testing, how well the blood clots that should be done. Because we know coagulopathy, clotting problems are common and expected with significant abruptions.
Right, to gauge how bad things are and guide treatment. And there was that interesting point about blood pressure, too.
Ah, yes. The notes point out that the mother's blood pressure may remain normal even when there's massive internal bleeding happening, especially in younger, healthier women who can compensate really well initially.
That's such a crucial pitfall to avoid. A normal BP doesn't mean everything's okay if the rest of the picture looks bad.
Exactly. Don't be falsely reassured by a normal blood pressure reading alone. Look at the whole clinical picture, the pain, the uterus, the baby's heart rate, any signs of shock.
Okay, so you suspect it strongly based on the clinical picture, maybe it's supported by CTG or even ultrasound. What's the immediate urgent management plan according to these notes?
Right, management. The note stresses tailored. Depends on how severe the abruption seems, how far along the pregnancy is, the gestational age, and crucially, the condition of both the mother and the baby.
And what's the absolute #1 priority?
Resuscitate and stabilize the mother. That comes first. Before making the final call on delivery, The notes even mention a Cochrane review didn't find specific high-quality trial evidence, like randomized controlled trials, to guide the overall management strategy.
Which really underscores that it comes down to rapid assessment and experienced clinical judgment in the moment, doesn't it?
It absolutely does. Prompt action based on the presentation is key.
So what does stabilizing the mother actually involve? What are the steps?
For moderate or severe abruption, the notes lay out that classic ABCD approach, like in any major resuscitation. A and B, airway and breathing. Get high-flow oxygen on immediately. C is for circulation. This is huge here. Establish large-bore, IV access, big cannulas. Get blood sent off urgently cross-match, full blood count, coagulation screen. Position the patient tilted on her left side, the left lateral position, to help blood flow back to the heart, keep her warm. And then aggressive fluid resuscitation with warmed crystalloid or colloid fluids.
And blood products must be critical too, given the potential for massive bleeding and clotting issues.
Absolutely critical. The notes specifically say consider empirical transfusion, meaning give it based on high suspicion, even before all lab results are back of blood products like fresh frozen plasma, FFP, which has clotting factors, and cryoprecipitate, which is rich in fibrinogen. Sometimes central venous pressure, CVP monitoring, might be used to help guide how much fluid and blood to give.
That resuscitation phase sounds incredibly intense. Stabilize, oxygenate, get access, pour in fluids and blood products. What happens next? The baby and the delivery decision.
Right, that's the next critical step once the mother is being actively resuscitated.
Fair.
If the fetus is still alive, the notes suggest either moving quickly to a cesarean section, a C-section,
Okay.
or sometimes artificially rupturing the membranes, ARM. But if you do ARM, you have to be ready, absolutely poised, to convert to an emergency C-section immediately if the baby shows any signs of distress.
So speed is of the essence for the live baby. What if, tragically, the fetus has already died?
If the fetus is deceased, vaginal delivery is generally preferred if possible, as it's often safer overall for the mother than major surgery in the context of potential coagulopathy. However, the notes add a caveat. A C-section might still be necessary even with fetal demise, especially if there's massive uncontrolled maternal hemorrhage that needs stopping quickly via hysterectomy or other surgical means.
That makes sense. And steroids.
Ah, yes, the notes mention maternal steroids. If the bleeding seems to have settled somewhat, and delivery isn't absolutely imminent, and the gestational age is appropriate, usually less than 36 weeks, then giving steroids can help mature the baby's lungs before potential preterm delivery.
Okay, so the core principles seem to be stabilize mom first, aggressively, then make a rapid call and delivery, usually aiming for speed if the baby's alive, with the method depending on the baby's status and the overall severity. Fluids and blood are paramount throughout.
That's a perfect summary of the urgent management approach outlined. Now, thinking about outcomes, prognosis, and complications. As you'd expect, it really varies.
Depending on how severe it was, how quickly it was managed.
Exactly that. Mild cases, caught early and managed well, can actually have pretty favorable outcomes. But severe abruption, that carries really high risks for both mother and baby.
What are the main risks for the mother listed?
For the mother, the big ones are massive hemorrhage, needing significant blood transfusions, developing those severe blood clotting problems like DIC, often needing an emergency C-section, and having a higher risk of postpartum hemorrhage, PPH, even after the baby is delivered.
Okay, serious risks.
Yeah.
And for the baby.
The potential fetal complications are also really significant. Preterm birth is common, obviously. Fetal distress during labor, stillbirth, tragically. IUGR, uterine growth restriction, meaning the baby hasn't grown properly or just generally low birth weight. That high perinatal mortality rate we discussed earlier in severe cases. And importantly, the notes mention an increased risk of cerebral palsy among survivors.
Wow, those are just profound potential consequences. It really drives home why this condition is so feared and why getting that recognition and management right and fast is just absolutely vital. The impact on both lives can be immense.
It truly can be life-altering.
So finally, prevention. Given that the cause is often unknown, is there anything mentioned in the notes that suggests we can prevent it?
Well, direct prevention is hard if you don't know the cause. But the notes do reference one specific finding. It's from a 2020 meta-analysis.
Okay, what did it find?
It suggested that taking low-dose aspirin specifically, a daily dose of 100 milligrams or more, when it's being used for pre-eclampsia prevention.
Right.
And importantly, started early in pregnancy, at or before 16 weeks gestation. This strategy may also reduce the risk of placental abruption or antepartum hemorrhage more generally.
Oh, so that's really interesting. So it's not aspirin for abruption prevention directly, but aspirin for preeclampsia prevention started early might have a beneficial side effect of reducing abruption risk, too.
That seems to be the suggestion from that analysis, yeah. Especially relevant for women already identified as high risk for preeclampsia who might be recommended aspirin anyway. It's a potential added benefit.
A valuable piece of evidence, certainly. Okay, let's try and pull all of that together now as we wrap up this deep dive. We've really unpacked placental abruption using these notes, haven't we?
I think so.
Starting with the basic definition that premature separation and its immediate, potentially catastrophic consequences for blood flow and oxygen. We looked at the types, revealed versus that dangerous concealed type. The frankly scary epidemiology, especially that high perinatal mortality rate, and the whole range of risk factors, even though the primary cause often remains a mystery.
hmm We covered the pathophysiology, that disruption of the vital connection, the crucial need to consider differential diagnoses like previa and rupture. Then we detailed those really key clinical features to look for the pain, the bleeding patterns, and especially that classic woody uterus.
And clarified that critical point. Diagnosis is primarily clinical. Don't wait for tests if the picture fits.
Exactly. And then we walked through the urgent management, ABCs, aggressive resuscitation of the mother first and foremost, with fluids and blood products front and center. Then the rapid decision-making around delivery, depending on the baby's condition and the severity.
And finally, we touched on the sobering prognosis and potential complications for both mother and baby, and that intriguing hint about aspirin for prevention in some cases.
I think the absolute key message, the thing to really take away from all this, is that placental abruption is a clinical diagnosis. It demands rapid assessment, immediate management, because the potential for severe harm to both mother and fetus is incredibly high. Recognizing those signs and starting resuscitation promptly, it's literally life-saving.
And that's why this information is so high yield for you, the listener. Whether it's for exams or for practice, being able to recognize those signs quickly, knowing those first urgent steps, that knowledge can truly make a critical difference.
Which actually raises a really important point to ponder. We've talked about the ideal management, but given that the cause is often unknown and the presentation can be so varied, what do you think are the biggest challenges globally in making sure women everywhere get timely diagnosis and effective management for abruption? Especially thinking about resource differences, access to blood banks, emergency surgery.
Hmm. That's a really significant question. How do we ensure equitable outcomes for such a dangerous condition worldwide? Definitely something to mull over as you consolidate all this information. Okay, that brings us to the end of our deep dive into placental abruption, guided by these revision notes. We genuinely hope this breakdown has helped make this complex and critical topic clearer, more memorable for you.
And remember, really consolidating knowledge like this, whether it's through discussions, deep dives like this, or practice questions, it's absolutely essential for mastering these high-stakes topics, both for exams like the MSRA and for being a safe, effective practitioner.
Absolutely. And speaking of exam prep, if you are preparing for the MSRA, finding reliable, high-yield resources is key. You can find some excellent materials over at pastthemsra.com. And there are also some fantastic free resources available too, which you can check out at freemsra.com. Definitely worth looking at both. So thanks so much for joining us for this deep dive today. We really hope it's been valuable and helps this information stick.
Indeed. Until the next time we dive into another topic.